بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. We welcome everybody for the Oncology Conference, King Abdulaziz University. We welcome everybody, national, internationals, to our university. This university carries the name of King Abdulaziz, who united the kingdom, and we are very proud to carry that name. I hope all the international speakers recovered from the jet lag, because I woke this morning and I said good morning, nobody answered, so I'm sure some of them they're still asleep or half asleep. But I hope, you know, with our discussion, we're gonna bring their attention. We have the first session about breast cancer. My name is Adnan Mirdad. I'm a professor of surgery, general and thoracic surgery in King Abdulaziz University, and it happens that I'm interested in breast cancer. The first speaker, I apologize for not reading all the CVs, because mashallah, all of them, they have very beefy CVs. So I want to use the time in the lectures and the discussion. So I just introduced them by their last job, you know. But if anybody interested, it's in the manual, you can read it. The first speaker is Dr. Jaweed Yunus. He carries now the position of a medical oncologist at the London Regional Cancer Program. And this is not London, England, this is London, Ontario, which is in Canada, which is a great university and a great training place. Dr. Jaweed graduated originally from Lahore, Pakistan, and then moved and did most of his degrees in Boston, in the United States, and then he did his fellowship in South Carolina. Dr. Jaweed is going to be our first speaker and is going to talk about bone health and breast cancer. You still have 30 minutes, Jaweed. Huh?
Assalamu alaikum, and thank you very much for this invitation. I'm really honored to be here. My special thanks to my fellow Dr. Shadi Al-Khayat, who actually made it possible for me to come here and stand in front of you today. He gave me a topic that is probably not going to be covered, honestly, in 30 minutes, but we'll try. I'm going to present to you what happens to women in terms of their bone health when they have developed breast cancer, and I have tried to include almost everything that we would like to discuss. So our learning objectives for this morning would be to look at the physiology of the bone, what happens to it when the metastatic disease develops, and also the interventions that we try at the secondary and the primary levels, and what happens with these skeletal-related events, because those are the events that are taken into consideration when clinical trials are run. If you look at this diagram, you'll realize that bone is a dynamic tissue. It does not stay still. It has a deep interaction with various factors, and in fact, from a resting stage, it will develop some further resorption by the osteoclasts activation and its action. Once that is done, osteoblasts will come in, lay down the new bone, and the process begins again. A number of factors have been found to be interacting at this level, and they produce a number of advantages and checks and balances for this process. So you can see on the left of the diagram that the osteoblasts get activated by things like steroids, vitamin D, PTHRP, and that includes androgen and estrogen as well. And what they are doing is, now we know the pathophysiology of this, that they are producing a receptor activator of nuclear factor kappa, which is called RANK, R-A-N-K. RANK gets secreted by the osteoblasts and in fact gets to the receptor which is present on the osteoclasts. When this ligand binds the receptor, it activates the osteoclasts, and the osteoclasts start to function as chewing up the bones. So keep that in mind, because really the two most common interventions that we use these days in medical oncology depend on this particular pathway and the functionality of osteoclasts. So one of the agents that we commonly use now is denosumab, which is a monoclonal antibody. And what it is doing is it is binding with the rank ligand and inhibits it to bind with the receptor, and thereby inactivating the osteoclasts and not let them perform their function at all. On the other hand, when you use pimidronate or zoledronic acid, they both act by, once you inject them, they get deposited into the bone surface gets chewn up by the osteoclasts, and the osteoclasts get inactivated by the inhibition of mevalonate pathway inhibition. If you are using clotronate, that leads to ATP inhibition from a very similar pathway, and that's how it works. Are we really concerned about the bony metastatic disease? The answer is yes. It is very common, and it is differentially seen in a variety of cancers. You can see prostate and breast top the list, and almost 3/4 to 90% of the patients will develop bony metastatic disease once the advanced level disease is present. Lung cancer patients, on the other hand, present about 1/3 of the patients with the advanced disease to the bones. We are in an era where more and more interventions are available now to prolong the survival of our patients, and that's why many a times now medical oncologists and radiation oncologists and surgeons would be seeing patients with skeletal-related events, largely due to the impact of these new interventions to prolong the survival. You can see that breast, prostate, and lung are among the 3 listed here that have increased longevity, and thereby patients with SREs will be more freely diagnosed and treated. These skeletal-related events from the angle of a clinical trial include the pathologic fracture, spinal cord compression, surgery to the bone, and radiotherapy to the bone for pain. And if you consider these 4 issues, they essentially lead to a number of consequential problems to the patients, including the loss of autonomy, significant morbidity, their quality of life affected by all of these with the loss of functionality and the bone pain, and then, of course, the economic impact is always there. There are certain individuals that you can recognize by looking at some of the factors who may become more prone to developing skeletal-related events. Among those, some of the most identifiable factors are that if there have been a previous skeletal-related event, if there is a soft tissue extension present with the bony metastatic disease, if they have had an overall disease progression elsewhere as well as in the bones, and perhaps osteoporosis before starting the targeted therapy. These patients are really at risk for skeletal complications once the bone lesions develop. So please keep in mind that these patients may not develop symptoms, but can still develop an SRE later on. In the graph, you can see the first bar, which is the red color, shows you all skeletal-related events, but the 2 bars next to that are the ones that are showing the pathological fractures and the need to give radiation therapy to the patients. And you can see that most of these patients will belong to the first 2 categories. Of course, as we discussed, that loss of functionality as well as the pain affect the patients both from a physical, functional, and emotional angle, and therefore the quality of life gets reduced to these patients. In this slide, I have essentially summarized the 3 agents that we have commonly used against the bony metastatic disease from breast cancer. They are pimidronate, zoledronic acid, and denosumab. We have already discussed their mechanism of actions. Their adverse events are a little bit different. Pimidronate and zoledronic acid both go through kidneys, and you need to monitor the renal functions with it. Denosumab, on the other hand, does not go through the same pathway. It's a monoclonal antibody, so reticuloendothelial system is the clearance for this, and therefore no renal function compromise is usually seen with that. The acquisition cost, at least in Canada, is very comparable for all the 3 drugs. Let's take a case for breast cancer. And it's a very typical case that you will see most often in any of our clinics. It's a 63-year-old postmenopausal woman who was diagnosed with breast cancer in 2005. She developed a T2 lesion with lymph node involvement. It was a grade 2 differentiating tumor, hormone receptor positive, HER2 negative. She does have some clues in her history about the osteopenia, osteoporosis type problems, as her mother had a vertebral compression fracture. She has a smoking history as well as a body mass index which is towards the lower side, 21. She had her surgery in the form of a modified radical mastectomy. She had anthracycline-based adjuvant chemotherapy given to her. And then she started tamoxifen in July of 2005. Later on switched to an aromatase inhibitor, which she completed in July of 2010. She had a recurrent disease in 2011, and she presented with a lower back pain and shortness of breath. A staging workup in the form of a CT scan of the chest showed multiple pulmonary metastases, maximum of 2 centimeters in size, and the bone scan confirmed with an MRI that there was a disease present at the L4, L5 level with soft tissue extension. So chemotherapy was initiated by the medical oncologist and radiation oncology was consulted. And that is where we need to ask this question that what is the risk for this patient to experience a skeletal-related event? Mind you that she already has a back pain. So as we had discussed that about 73% of patients with advanced breast cancer will develop bony metastatic disease, and about 2/3 of them will have bony metastatic disease leading into these skeletal-related events. And once the patient has developed an SRE, it is likely that she will experience another SRE in a short interval of time. I wanted to show you some of the pivotal trials that have been done in this field so that you will get an idea as to why these agents are used. The first agent, clotronate, which is an oral therapy, was used. In fact, this is a Canadian trial. Dr. Sandy Patterson from Alberta was the PI for this study and presented this. It essentially randomized the patients into clotronate versus placebo for about a year and a half. And you can see that the cumulative of the skeletal events compared to placebo clotronate was better in decreasing down the SREs. Hartabaji from MD Anderson presented this paper in 1990s where the metastatic disease patients from breast cancer were randomized to receive pimidronate as 90 milligram infusion and was compared to placebo. And in fact, very clearly showed the advantage of pimidronate by reducing down these skeletal-related complications with a very high statistical p-value. Third came zoledronic acid, which again, from the very same angle compared to placebo in this trial, showed a very similar outcome that all the patients in the trial, as well as the patient with prior fractures, were really benefiting from the use of zoledronic acid in reducing down the SREs. The most recent molecule that has come into the market is denosumab. This trial by Stopic saw the comparison between denosumab and zoledronic acid. Zoledronic acid is a subcutaneous injection, 120 milligram, which is given the same schedule as once every 4 weeks, while zoledronic acid is a 4 milligram IV. This was continued, but in a very different trial, which essentially looked at initially first the non-inferiority establishment, and once that was met, it went into establishing a superiority outcome. And in fact, both of those outcomes were positive, and there was about an 18% reduction over and above zoledronic acid. Mind you that the previous trials were compared to placebo. This trial was in fact comparing two frontline most active agents against each other. As a physician, while looking at these patients, pain seems to be the most common element, and one of the good outcomes seen in this study was to see the moderate or severe pain was delayed with denosumab, as well as the patient who have had no pain or mild pain at the baseline also had longer time to develop painful metastatic disease in the bones. The problem with the bone loss is quite common with the patients who have bone disease, not only in the metastatic setting, but otherwise as well. So I just wanted to spend a few minutes to show you why we are concerned about the bone all the time in the patients with breast cancer. Estrogen and androgen both have a very close role in the bone resorption as well as bone formation, and I have shown you this slide in a different format before. But keep that in mind because the trial strategies in adjuvant therapy for breast cancer has largely involved aromatase inhibitors more recently. And no matter what trial you look at, whether or not they were used upfront, like in ATAC trial or the Big 198 trial, or used as a switch strategy, for example, the two other arms for Big 198, Arno trial or others, they all have one common problem at the end. If you look at the ATAC trial data, which is probably the most comprehensive one and likely available for a huge number of years now, the fracture rate over time seems to be definitely more common in the arm with anastrozole compared to tamoxifen. And in fact, tamoxifen, if you look at the EBCTG data previously, it clearly showed that the postmenopausal women in fact benefit from using tamoxifen because it strengthens the bones and decreases down these skeletal related events. Decrease does not mean zero, but it certainly improves. Aromatase inhibitors do the opposite. And you can see that the difference in the two arms was about 3.5%. A very similar data came out from Big 198, and Big 198 compared letrozole against tamoxifen either as a straight head-to-head comparison or switched in between. The bone fractures were certainly much more common in letrozole arm, although if you look at the fracture rate as a percentage, the difference is 1.5 versus 2.2. MA17 study, which is another Canadian study that looked at an extended adjuvant treatment, which is tamoxifen used for 5 years, after which letrozole was used for another 5 years, again showed a very similar picture of osteoporosis or bone fractures. However, this trial did not prospectively found out about that, and in fact it was a patient-reported data most of the time, but again showing a very similar picture. The point is that when you have a patient with breast cancer, there are a number of things that are done to this patient either iatrogenically or by the disease activity that reminds you constantly about the bone health and how you would like to take care of it. So in this slide, you can see that the menopause remains around 1 to 2% as a risk for the loss of bone mineral density, for example, at lumbar spine. But as soon as you put someone on an aromatase inhibitor therapy, it starts to rise. And in fact, a premenopausal woman made postmenopausal by the use of the GnRH analogs, to which you add an aromatase inhibitor, jumps up to almost 3 times the normal. And similarly, if you have given chemotherapy to someone who is premenopausal or perimenopausal and made them postmenopausal, then it jumps up to about 3.5 times. The interventions that we have discussed so far, including the pimidronate, denosumab, zoledronic acid, do have side effects, and therefore you really need to have a quick review of those. The acute phase reactions, when you infuse these agents, the patient experiences a flu-like syndrome with the eyes watering, congestion at the upper nasal sinuses, etc. Those are seen a lot more commonly with pimidronate and zoledronic acid. It is much less common with denosumab. The other ones, including the arthralgia, chills, bone pains, are very similar to each other or very slightly different otherwise. As I had mentioned to you, that denosumab is a monoclonal antibody and is utilized or metabolized by the reticuloendothelial system. It does not go through kidneys, and therefore the potential renal toxicity adverse events are far less in denosumab arm compared to pimidronate or zoledronic acid. You need to monitor creatinine level. More recently, FDA Canada issued a warning about denosumab that it causes hypocalcemia. This is nothing new for bisphosphonates or with the denosumab. And what we prefer is that we follow these patients at least for the first 6 months with calcium levels done once every month or once every 3 months. Osteonecrosis of jaw, being a very uncommon problem, still exists with both denosumab as well as zoledronic acid, and may be related to a completely different array of problems and factors affecting the jaw and producing this complication. Fortunately, it's a very low occurring problem. Lastly, I just wanted to touch base with a sort of a controversial topic, although I think that the data is rapidly accumulating and we are soon going to reach a fair point at which we can decide about our patients what to do. Does the use of these agents provide a survival advantage? The first clue came from the NSABB-B34 study. Again, Sandy Patterson from Alberta was the PI for this study, and he presented it several times in the last several years. Initially, the use of clordronate in patients against placebo in the adjuvant setting for breast cancer did not show a significant improvement in the survival. In fact, the non-bone metastatic free interval was the only positive thing. However, if you look at the data for the patients who were 60 or 60 plus at entry, they all had a fairly decent outcome and an advantage compared to the patients who were younger than this age group. Then came the data from ZOFAST. The ZOFAST trial by Dr. DeBoer was presented a few years ago. And in fact, this trial was only looking at patients who have had breast cancer and were hormone receptor positive. They were treated with letrozole right up front. They were treated with letrozole in both arms, but they were given zoledronic acid either right up front with letrozole therapy or given at a time when there was a clinical need for that. And in fact, the trial was positive for the endpoint that it was searching, which was the improvement in the lumbosacral bone mineral density. They did very well with that, and you can see that they all improved significantly. However, one side improvement that came in was the disease-free survival. The ZOFAST data clearly showed that there is a 34% advantage for the patients who were given zoledronic acid, that they are going to survive without the disease recurrence longer than the other patient group. And in fact, if you look at the distribution of the disease recurrence, although the bone part was certainly prominent, there were other areas, including the local and the contralateral breast area recurrences, that were improved in the arm given zoledronic acid. The zoledronic acid was only used as a 4 milligram IV infusion once every 6 months for 6 doses in total or 3 years. The overall survival was unaffected with a non-significant p-value. Michael Ganant from Austria presented ABCSG12 study. And in fact, this study was very interesting in the sense that it was looking at patients who were premenopausal but were made postmenopausal by the use of goserlin. Once you had achieved that after the surgery, they were randomized 1:1:1 for 4 arms. The primary comparison was between tamoxifen and anastrozole. However, then zoledronic acid was also given as another randomization. There was no difference in the outcome between tamoxifen and anastrozole arm. So the premenopausal women made postmenopausal given tamoxifen or anastrozole had no difference in the outcome. But as soon as you start looking at the Zometa arms, it definitely looked that it improved the disease-free survival compared with the endocrine therapy alone. And in fact, a very similar outcome, which is in the form of about 28% improvement in the disease-free survival, was seen with Zometa. And in fact, a very similar picture appeared with the distribution of these events. As you can see that the contralateral breast cancer, the distant recurrences, local regional recurrences, they all were positively affected by the use of zoledronic acid. If you look at the survival data, and interestingly enough, these patients were not treated with adjuvant chemotherapy, but only adjuvant hormonal therapy, they all did very well, and 3-year survival from 99% went down to only about 95.5 at 7 years. And in fact, there was a positive impact of zoledronic acid in terms of the overall survival advantage. And the survival advantage with the statistically significant p-value was almost up to about 37%. Azure trial, on the other hand, looked at the patients over 3,000 in number. It's still in the adjuvant setting, but with a mix of pre- and postmenopausal to find out really if we can answer the question once and for all whether adding zoledronic acid will make a huge sense. Now, compared to the other trials, this trial, zoledronic acid, was used almost at an industrial dose strength. 6 doses initially every 3 to 4 weeks, 8 doses every 3 months, and then 5 doses every 6 months. And this slide is just to show you that the premenopausal women were about 750 in both arms, but the one that we need to concentrate on is over 5 years postmenopausal, are a little over 500 in both arms. The Azure was also used as a neoadjuvant setting trial, and in fact showed that the combination of zoledronic acid produced a better tumor reduction as well as a pathologic response. But once the trial was mature and presented, it did not show a difference between disease-free survival and overall survival comparing zoledronic acid versus placebo. That was a very surprising and unexpected result. But as soon as you start to, again, divide these patients according to their low estrogen environment, which means that the women who were over 5 years postmenopausal versus those who were not, you can definitely see that about a 30% overall survival advantage starts to appear, very similar to the previous trials of Zofast, ABCSG12, as well as chlorogenic acid. Again, the overall survival for the 5-year postmenopausal patients were a lot better and definitely positive compared to the pre-peri or unknown menopausal status. Has this effect of bisphosphonate therapy only restricted to breast? The answer is no. If you look at 2 other trials that I'm briefly going to show you, you can see that the same or a similar pattern appears. In myeloma patients, zoledronic acid was compared to clordronate, and essentially the endpoint was progression-free survival and overall survival. And in fact, the data, very similar to the breast data, showed about a 16% advantage for overall survival for the Zometa arm and about a 12% for the progression-free survival. How about lung cancer? So Scagliardi data that just came out and was presented in 2011 and again this year at another meeting took the patients who were bisphosphonate naive but had lung cancer with bony metastatic disease present. One arm used denosumab 120 milligrams subcutaneously, and the other arm used Zometa 4 milligram IV. Now you should remember that the previous trial with Zometa versus placebo had shown a survival advantage in non-small cell lung CA. A little one, but certainly present. So this one was very interesting, that overall survival with the patients with non-small cell lung cancer showed a clear advantage for denosumab. The number of months may not be very different, but it's still about 6 to 7 weeks difference between the 2 arms. Now, as medical oncologists, we all get excited about lung cancer because even a small increment in the overall survival is a huge advantage to us and, of course, to the patient. So at the end, I just wanted to recapitulate that no matter what guidelines you look at, either ASCO, NCCN, your local, national, or international, the anti-resorptive therapies, which now include the clotronate, bisphosphonates with the Zometa and zoledronic acid, as well as denosumab, appear to be standard arms of therapies. And as we pointed out, that the patients who do develop bony metastatic disease or those who are at high risk of osteopenia, osteoporosis can all be treated with that, prevention as well as the treatment side. So with this, I'll end my talk. Thank you.
Thank you. Thank you, Dr. Jaweed, for a very informative lecture and sticking to the time. Our next speaker is Dr. Ahmed Al-Shehri. Ahmed is a graduate of this university, and then he completed his medical training at Dalhousie, Halifax, moved to Edmonton, where he completed his clinical oncology training. Now he is the head of the medical oncology department at the Princess Noura Hospital in the National Guard Hospital in Jeddah. Ahmed will be talking about advances in adjuvant treatment, and I guess he's talking about adjuvant treatment for breast cancer. Okay, got 20 minutes, Ahmed. Huh?
Thank you, Dr. Mirdat. Thank you. So, Assalamu alaikum wa rahmatullahi wa barakatuh. I would like first to thank the organizing committee for inviting me for this presentation and this unique conference. And I would like to thank our chairman here for this nice introduction. My part will be talking about the updates and management of early stage breast cancer. So to understand what's new in this field, we have to understand the basics of treating early stage breast cancer. Probably most of us, we know that early breast cancer should be first managed with definitive surgical resection, followed by adjuvant systemic therapy, and then adjuvant radiation treatment if either of these two were indicated or is indicated. Talking about systemic therapies, it depends on the biomarkers of this breast cancer, whether we have ER, PR positive disease, HER2 positive or negative disease. And then we have like 4 different groups of breast cancer that can be treated differently with regard to the adjuvant treatments. So we have the ER positive group, we have the ER negative group, we have the HER2 positive group and the HER2 negative group. So the question now, why adjuvant systemic therapy? Why should we give chemotherapy or any kind of systemic therapy to our patients? And when to consider adjuvant chemotherapy specifically, and what adjuvant chemotherapy should you consider? Okay, why do we give adjuvant systemic therapy? Of course, we know that despite the fact that some of our patients will present with early stage breast cancer, and despite the fact that like some of them might have definitive surgical resection, there is like a good percentage of these patients might develop distant metastasis. So this will convert them from incurable stage into from curable to incurable stage. And the risk of this kind of shift from curable to incurable will be dependent on the stage of this breast cancer. So the more advanced the stage, will have more risk for this kind of shift to the incurable stage. So this is why we give systemic therapy, namely chemotherapy, to prevent this kind of transfer. So the more they advance the stage, the more indication for chemotherapy in such cases. What kind of, what are the exact indications to give adjuvant chemotherapy? I mean, there are certain classic kind of factors that we look at. One of them is the lymph node status. So if patient has like positive lymph node upon surgical resection, most likely she will go for chemotherapy. If she does have negative lymph node status, so no lymph nodes involved, so the second most important factor would be the tumor size. And depending on this tumor size, we rely on other factors listed here with regard to the patient age, other biomarkers, so we can see if there is an indication for such like chemotherapy. In this particular group, if the patient has negative lymph node and she has ER positive disease and HER2 negative disease, now we have what's called the 21 gene assay or the Oncotype DX to determine who are the patients who have a high risk of disease recurrence or relapse, then chemotherapy will be justified in such patients. What kind of chemotherapy, if it's indicated? Like almost 10 years ago, these were the standard of care, CMF, AC, FIC50. Okay, and several studies have indicated that these chemotherapies might be equivalent to each other. So all of them were acceptable at that time. So more recently, we had this kind of comparison, anthracycline-based versus CMF, and anthracycline was superior. The same for KIF, again a CMF, KIF was superior. Then we have noticed that addition of taxane to anthracycline might be superior. And also, we had this kind of direct comparison between taxane and anthracycline, and we found that taxane-based chemotherapy was superior. Okay? The FIC100, if we increase the dose of eberobicin to 100 milligram, was superior to 50 milligram dose. Okay, talking about the third generation chemotherapies, okay, TAC was compared to FAC and it was superior. Okay, both ACT and the AC paclitaxel weekly base were superior to ACP like Q3 weeks. So these two are acceptable kind of adjuvant chemotherapies nowadays. Okay, and we have this kind of comparison between TAC and ACT, and we didn't find a big difference with regard to the overall survival. There was like a slight trend towards improvement of overall survival here, but it was not statistically significant. So TAC still might be considered like an acceptable adjuvant option. Okay, this kind of comparison between this chemotherapy and this one showed that the dose-dense chemotherapy was superior. And here also, the FIC-T, 3 cycles of FIC followed by 3 cycles of T, was superior to FIC100. And finally, these two were comparable to each other. Having said that, these 6 chemotherapies or 5 regimens are considered the most recent chemotherapies that we're gonna use, especially in lymph node positive breast cancers. TC still might be an option for lymph node negative disease. So, what are the updates over the last year? Actually, no major advances over last year with regard to the adjuvant chemotherapy. However, we have this kind of condition where we have some of our patients might have a local recurrence, and after complete surgical resection of the local recurrence, it's a common practice that we give them few cycles of chemotherapy But we didn't have an evidence for that. Actually, we used that just a matter of satisfying ourselves, satisfying our patients that we give them more insurance that this disease will not recur back. Until the San Antonio this year, where they presented an interesting study. So what types of local recurrences do we have? We have mastectomy, those patients who have mastectomy without radiation, and then we have a group of patients who had mastectomy with radiation, and other patients who had breast conserving surgery plus radiation. So in either condition, the treatment will be different. For those who had mastectomy without radiation, they have to have local excision plus radiation. If they had mastectomy with radiation, then local excision alone. If they had breast conserving surgery plus radiation, then mastectomy and possibly axillary lymph node dissection. And as I mentioned, most of these patients were used to be treated with adjuvant chemotherapy or few cycles of chemotherapies, but with no solid ground and no evidence to support this practice. Okay, in the San Antonio, which was held almost 5 weeks ago, they presented an interesting trial called the CALOR trial. It stands for Chemotherapy as Adjuvant Locally Recurrent Breast Cancer. They are trying to test the hypothesis of benefit of giving few cycles of chemotherapy after complete surgical resection of locally recurrent disease. So they included patients with locally recurrent disease. They excluded patients with supraclav lymph nodes positive disease. Okay, and what they did exactly, they randomized them after having definitive surgery into chemotherapy arm versus no chemotherapy arm. Of course, endocrine therapy and HER2-directed therapy were given as per the choice of the treating physician and if there is an indication to give so. Chemotherapy was chosen by the investigator. There was a recommendation to use more than 2 types of chemotherapies. And radiation was recommended, but of course, if it was if the resection came up with positive margin, it was clearly indicated to give at least 40 gray of radiation. So as you can see, despite the fact that we had 2 groups, one chemotherapy group, the other group with no chemotherapy, but we see that the treatment group didn't have the same kind of treatment. So chemotherapy, different kinds of chemos, might be one type of chemo, might be more than one type of chemo. There might be Herceptin, there might be some endocrine therapy. So the intervention itself is not clearly defined, apart from the fact that they receive some sort of chemotherapy. Anyway, originally they designed the study to recruit almost 1,000 patients. And in 2008, it was amended to be 265 patients due to slow accrual of patients. And in January 2010, it was closed actually with 162 patients. So it was very, very slow accrual due to the fact that most people, they practice to give chemotherapy after local resection. They didn't accept to give the chance the patient will go with no chemotherapy arm. So this will add also to the limitation of this study. As you can see, with regard to the patient characteristic, we don't see big differences, and even if there is some sort of difference here, remember that the number of patients is not that big. So it was 85 patients in the chemotherapy arm and 77 patients in the treatment arm, and these are the different treatments that have been given to either group. As you can see from the chemotherapy arm, almost 1/3 of them, they get monochemotherapy. 2/3 they get 2 types or multiple types of chemotherapies or polychemotherapy. And you can see the distribution of such groups. Okay, coming to the results, you can see there is a clear separation in favor of the chemotherapy group arm. So we had almost 69 5 years disease-free survival versus 57% in the no chemotherapy arm, with significant p-value and confidence interval here. So the number of local recurrences, percentage, almost 24% versus 34% in the no chemotherapy arm. And with regard to this kind of benefit, it was more pronounced in the ER negative group, where we don't have a big difference talking about ER positive disease. So if we're gonna use this kind of treatment, keep in mind that ER negative patients might get more benefit as compared to ER positive patients. With regard to multivariate analysis, they found that the interval from primary surgery was one of the most important factor to consider such an approach. So the longer the period from the primary surgery, the more the benefit to get, to give chemotherapy. And the same, whether to give chemotherapy versus none, it was found to be an important determinant factor and prognostic factor here. With regard to the overall survival, again, we see there is a clear separation in favor of chemotherapy arm, which was significant. But we don't see the same trend we saw in the disease-free survival. So there was no difference with regard to the benefit talking about ER negative or ER positive disease. Again, with regard to the multivariate analysis for overall survival, both interval from primary surgery and the giving chemotherapy were the most important prognostic factors favoring the positive impact on those patients who received chemotherapy. So as a conclusion of this study, adjuvant chemotherapy post-complete surgical resection of a locally recurrent disease resulted in improvement, significant improvement in disease-free survival and reduction of disease recurrence by 41% and reduction of death by almost 60%. With regard to disease-free survival, most of the benefit was seen in the ER negative disease. So adjuvant chemotherapy might be recommended after complete surgical resection. Data was strongest, as I mentioned, for AR negative disease. However, we need to have longer follow-up for patients with ER positive disease to document the exact benefit of using chemotherapy in such group. Again, this is a small study, but again, it will give us some sort of assurance that our practice to give adjuvant chemotherapy after local recurrence resection might be beneficial. What about adjuvant endocrine therapy? The standard of care in premenopausal ladies is tamoxifen, and we know the evidence from the Oxford meta-analysis, and we see that there is like 15-year disease-free survival benefit of almost 15%, with 15-year overall survival benefit of almost 10%. Postmenopausal ladies, again, tamoxifen would be a reasonable option. On top of that, we have upfront aromatase inhibitors like anastrozole or letrozole can be used, and we have disease-free survival benefit using this approach. Overall survival benefit was not statistically significant. Switching approach, like using tamoxifen for 2 to 3 years, then switching to aromatase inhibitor, most likely exemestane, also have been proven to have disease-free survival and overall survival benefit. The sequencing approach, like 5 years of tamoxifen followed by 5 years of letrozole, also resulted in disease-free survival and overall survival benefits. So all of these are reasonable options for postmenopausal ladies. So again, to have it represented in a graph, in premenopausal ladies, tamoxifen 5 years will be the standard of care. In postmenopausal ladies, tamoxifen for 5 years will be again an acceptable kind of practice. Tamoxifen for 5 years followed by AI for 5 years, like letrozole, might be a benefit. The switch approach, tamoxifen followed by AI, like 2 to 3 years, followed by 2 to 3 years of AI would be another approach. And again, upfront aromatase inhibitor for 5 years would be an acceptable approach. However, we have new data here. What if we extend the tamoxifen treatment to up to 10 years instead of 5 years? Do we have an evidence to do so? Actually, again, another study which was presented at the San Antonio 5 weeks ago is called the ATLAS study, stands for adjuvant tamoxifen. Longer, again, is shorter, like 10 years versus 5 years of tamoxifen. Again, the rationale, we know that 5 years of adjuvant tamoxifen resulted in 15% reduction in the risk of disease recurrence at 15 years, and 10% in the reduction in the risk of death at 15 years. Okay, and you can see here, like 5 years of tamoxifen versus none resulted in a significant hazard ratio of almost 30% from 0 to 4 years. At 5 to 9 years, it was almost in the range of 34%. More than 10 years, it was in the range of 25 to 27%. So this is what's called the carryover effect, despite the fact that tamoxifen was given only for 5 years, but you can still see this kind of benefit with regard to risk of death continues at 10 years and at 15 years. Okay, the design of this study, after completion of 5 years of adjuvant tamoxifen, patients had been randomized to tamoxifen for 5 years versus no further tamoxifen. Okay, and as you can see, okay, the benefit was more pronounced for the 10 years tamoxifen, where we had like less recurrences as compared to the 5 years tamoxifen, and even less mortality as compared to 5 years of tamoxifen. So there was a disease-free survival and overall survival benefit using 10 years of tamoxifen. Interestingly, it was found that there was a little effect during the 5 to 9 years period. So despite the fact both groups had been treated for 5 years of tamoxifen, after that, one group continued for an extra 5 years. During these extra 5 years, there was no big difference between the two groups. But after the 10 years, we started to see the difference between the two. As you can see here, this is at 5 years at the beginning of the study. Disease-free survival. From 5 to 10 years, we don't see a big difference. There was some difference, but it was not big. But after 10 years, we started to see more clear separation between the two arms in favor of the 10 years of tamoxifen. Overall survival at 10 years, you can see from 5 to 10 years, there was almost no benefit at all. But after the 10 years, we started to see the benefit of the extra 5 years of tamoxifen. So this again underscores the importance of the carryover effect of using adjuvant tamoxifen. Back to our table that I explained at the beginning. So from 0 to 5 years, there is no big difference from 10 to 5 years, like 10 years of tamoxifen versus 5 years of tamoxifen. 5 to 9 years, again, the hazard ratio was not significant. But again, if you consider more than 10 years, there was a significant trend, like almost 30% risk reduction of death by using 10 years of tamoxifen versus 5 years of tamoxifen. Using these two data, the investigators have predicted the benefit of using 10 years of tamoxifen versus none. And you can see the hazard ratio was significant all over, from 0 to 5, from 5 to 9, and for 10 plus. So in summary, 10 years of tamoxifen reduces breast cancer mortality by almost a third in the first decade and almost a half in the second decade after starting tamoxifen as compared to no tamoxifen treatment at all. What about the risk, like endometrial cancer and breast cancer mortality? You can see 10 years of tamoxifen versus none. We can lose almost 0.4% of patients by using such an intervention. However, we can gain almost 12%. So 12% of the patients' lives might be saved by using the 10 years of tamoxifen versus none. The same would apply if we consider 10 years versus 5 years of tamoxifen. As per the Atlas trial, we had like 0.2% loss, but again, we had a total net of 3% life gain by using more tamoxifen as compared to shorter duration of tamoxifen. So we still have future studies to come. In 2013, this year, we will have the more mature data of the ATOM trial, which is exactly copy-paste of the Atlas trial. We will have the more mature meta-analysis data of the X4 meta-analysis, 10 versus 5 years of using endocrine therapy. And again, in 2017, we'll have 5 more years of the Atlas follow-up. So we'll have more and more data to come in the next few years. The questions will arise here with regard to the duration of tamoxifen. Is it better than the switch approach? We know that the switch approach is better than 5 years of tamoxifen. 10 years of tamoxifen is better than 5 years of tamoxifen. So which one is more beneficial to our patient? We don't know the answer yet. Again, 10 years of tamoxifen better than sequence approach, like 10 years of tamoxifen as compared to tamoxifen for 5 years, followed by letrozole for 5 years. We don't know the answer. And again, 10 years of tamoxifen versus 10 years of AIs in postmenopausal ladies. We don't know the answer yet. And of course, we don't know whether the effect is because of the continuation of tamoxifen or continuation of any kind of endocrine therapy. So should we continue indefinitely with tamoxifen or any kind of endocrine therapy? Should we recommend our ladies to do so? We don't know the answer yet. But however, based on this data, I think tamoxifen for 10 years might be considered, like in the near future, to be a standard of care in pre- and post-menopausal ladies. The last discipline that I'm going to talk about is the adjuvant trastuzumab. It's indicated whenever chemotherapy is indicated and whenever the patient has HER2 positive disease. Okay, these are the 4 major trials using adjuvant Herceptin, either concurrently with taxanes or sequentially after finishing taxane chemotherapy. Okay, and based on these 4 trials, we concluded the following, that trastuzumab is an essential component of the adjuvant treatment of HER2-positive breast cancer. All breast cancer patients have to be tested for HER2 presence or immunohistochemistry stain or by gene amplification using FETCH technique. Trastuzumab is indicated if node-positive disease and in node-negative disease if the tumor size 1 or more centimeter, and this is as per the NCCN guidelines. The standard duration of trastuzumab therapy is 1 year, as per the 4 different trials that I just showed you right now. The question should arise now with regard to the exact duration. Like, is 1 year, is it too much or too little for our patients? Actually, 2 studies have addressed this kind of question over the last year when presented. One of them is the FAIR trial, which was presented in the ESMO 2012, comparing 6 months of trastuzumab versus 1 year of trastuzumab. The other trial, which is the well-known and famous trial, the HERA trial, which was presented again in the San Antonio 5 weeks ago, comparing 1 year versus 2 years of adjuvant trastuzumab. So the standard of care is 1 year of trastuzumab. We are comparing shorter duration, 6 months, or longer duration of 2 years. Well, let's start with the FAIR trial first. Okay.
Ahmed,
I'm sorry?
we passed our time.
Okay, just I will pass through it quickly, inshallah. So 6 months of trastuzumab, either to continue up to 12 months or to stop at 6 months. And they included a huge number of patients, over 3,000 patients, and have been randomized between the 2 arms. In summary, the design was non-inferiority like a study design. They want to prove that 6 months is as good as 1 year. And what they found, that the confidence interval did not reach the non-inferiority limit defined at the beginning of the study. So their conclusion was that 6 months is not non-inferior to 12 months of trastuzumab, and 12 months would still be the standard kind of duration for adjuvant trastuzumab treatment. The other trial is the HERA trial. It was actually designed many years ago, several years ago, and we had the data of 1 year trastuzumab versus none, and it was superior. And now we have the data to compare 1 year versus 2 years. And the baseline characteristics were not different between the 2 groups. As you can see, both 1 year and 2 years were exactly the same with regard to disease-free survival. Talking about ER/PR negative disease versus ER/PR positive disease, we had some sort of benefit here at 2 years using 2 years of trastuzumab, but this kind of benefit didn't sustain in the following years. And overall survival was not different between the 2 arms. And we had also more mature data with regard to the 1 year versus no trastuzumab adjuvant treatment, and we found that this kind of effect was sustained. So 1 year of trastuzumab, as per this study, would still be the standard of care. So none, no 6 months and no 2 years of trastuzumab treatment. So as a take-home message, 3 different kinds of systemic therapies we might consider: chemotherapy, HER2-directed therapy, endocrine therapy. For adjuvant chemotherapy, after complete resection of local recurrence might be beneficial. Longer adjuvant endocrine therapy might be better than 5 years only. And 1 year of adjuvant trastuzumab stands again as the optimal standard duration of treatment in HER2-positive disease. And I think this would be my last slide. Thank you.
Shukran, Ahmed. Thank you, Ahmed, for this informative lecture about the adjuvant treatment of breast cancer. Our next speaker is Dr. Syed Mustafa Karim. He carries the position of the head of the multidisciplinary breast cancer program at the King Faisal Specialist Hospital in Jeddah. Dr. Karim graduated from Dow University in Pakistan, and then he completed his training in Detroit in the United States, Michigan. They moved to Washington, D.C., to Pennsylvania, and then finally he landed in Jeddah. He's most welcome. His speech is going to be about update on the treatment of advanced breast cancer. We moved from early to advanced. And Dr. Karim, I remind you, 20 minutes.
Thank you very much for the kind introduction and for allowing me the opportunity to present to you today some advances in the treatment of metastatic breast cancer in 2012. So as opposed to tamoxifen, which made most of the news in the adjuvant hormonal treatment of breast cancer last year, it was mainly aromatase inhibitors that made most of the highlights in 2012, not only in combination with other interesting novel agents, but also in comparison with other hormonal agents, including fulvestrant. So we're going to touch upon a few of this data and some chemotherapy updates, and a couple of upcoming interesting agents in the treatment of HER2-positive breast cancer. So starting off with hormonal therapy, as we know that when we treat patients with hormonal therapy in general, and with aromatase inhibitors in particular, we at some point face resistance. And this resistance, in most cases, what we found is that the mechanism of such resistance has to do with overactivation of this pathway called the mTOR pathway. mTOR, which stands for mammalian target of rapamycin, starts to get activated by ER-independent signaling by growth factors and hormones and even glucose. And this leads to cell proliferation and growth and apoptosis. And we have seen in both preclinical and clinical studies that inhibition of mTOR by this agent everolimus has led to decreased growth and angiogenesis and glucose uptake and inducing response in some patients. So these trials basically led to this large pivotal landmark phase 3 study called the BOLERO-2 study. In a similar population of patients, these patients had already failed a non-steroidal aromatase inhibitor, namely letrozole and anastrozole, and they were randomized in a 2-to-1 fashion to receive either exemestane, which is a steroidal aromatase inhibitor, which is an option for treatment for these patients, with or without this agent called everolimus at a dose of 10 milligrams per day. This was a fairly large study. More than 700 patients were enrolled. And initially, after a few months follow-up, we saw that there was progression-free survival benefit. And these are the results from the San Antonio breast cancer meeting, which was just held last month, still showing at 18-month follow-up that there is a significant progression-free survival benefit of adding everolimus to exemestane. And at 18 months, the survival benefit has increased from about 4 months to 11 months, so more than doubling of progression-free survival. And this was not at the expense of too much toxicity. With the addition of everolimus, we saw in 8% of patients some stomatitis. Pneumonitis is another feared complication in about 3% of patients. And FDA specifically warns discontinuation of everolimus in case of pneumonitis symptoms or signs on CT scan or chest X-ray. So BOLERO-2, the advantages are that this is an all-oral regimen. So exemestane and everolimus both are oral agents, and they can provide doubling of progression-free survival, which basically means that we can delay the need for chemotherapy for these patients up to, as we saw the results, up to possibly 11 months. We don't have overall survival data available yet, but soon to be available. The disadvantages, on the other hand, are that everolimus is still a costly agent, and that some critics argue that the control arm of BOLERO-2, which was exemestane only arm, was probably a weak arm, and most physicians probably would not consider it as a valid option for these patients, but that is open for discussion. But nonetheless, these significant results have led to this designing of this adjuvant chemotherapy trial, incorporating everolimus in the adjuvant therapy. This trial started accrual in September 2012, and the target accrual is 3,500 patients. These patients, after completion of their chemotherapy, will be started on hormone therapy with or without everolimus. So they will be given everolimus or placebo, and everolimus will be for a duration of 1 year, and they will be looking at progression-free survival and overall survival. So we'll have to wait for a few years to see whether there is an effect of everolimus in this setting. But nonetheless, for metastatic breast cancer, FDA has already approved everolimus for use in postmenopausal patients with ER/PR-positive HER2-negative disease after failure of letrozole or anastrozole in combination with exemestane. And NCCN has basically done the same. So it's an option that is available, and including myself, physicians have started using it in their clinical practice. Another example of a targeted agent which was combined with an aromatase inhibitor is this agent called PD033291, in short PD991. This agent basically targets cyclin-dependent kinase 4 and 6, and thus basically keeps this agent in the hypophosphorylated state, and thus preventing retinoblastoma gene inactivation and preventing progression of the cell cycle from G1 to S phase. So this agent was evaluated in a randomized phase 2 study of 165 patients who were randomized in a 1-to-1 fashion to receive either letrozole or a combination of letrozole and PD991. This molecule was given at a dose of 125 milligrams per day. Initially, the trial was accruing all comers, all ER-positive, HER2-negative patients, but later on, some basic science studies showed that the cell lines that were most likely to respond to this agent were cell lines which had loss of P16 and CCND1 amplification. And so after accrual of about 100 patients, the accrual was limited to patients who had these molecular changes. So when we saw the results, they only looked at progression-free survival because this was a phase 2 study. What they saw was a significantly increased progression-free survival benefit favoring PD991 and letrozole combination, which improved from 7.5 months for single-agent letrozole to 26.1 months for the combination. So these were pretty interesting results, and side effect-wise, there was basically not much except hematologic toxicity that was added by PD991. So these results basically have led to designing larger phase 3 clinical studies, which are going to in the future evaluate this agent. So in addition to tamoxifen and aromatase inhibitors, another third class of hormonal agents that is available for treatment of metastatic breast cancer is called fulvestrant. Fulvestrant is a direct estrogen receptor antagonist, and basically leads to downregulation of the estrogen receptor over time when you start treatment of breast cancer patients with this agent. After approval by FDA into the third-line hormonal setting a few years ago, there was still some controversy about the loading dose of fulvestrant. Initially, it was approved at the dose of 250 milligrams intramuscularly in day 1, 15, and 28, and then monthly. Later on, basically, there was some speculation that the 500 milligram loading dose might be superior. So a few years ago, this trial was initiated. This is a phase 3 trial called the CONFIRM trial, which directly looked to answer this question of whether 500 milligrams is better than 250 milligrams. And initially, we had seen a progression-free survival benefit. So most physicians actually changed their practice to incorporate 500 milligram dosing for loading dose. In San Antonio meeting last month, there was actually an update of this, and now they presented a secondary endpoint, which was the overall survival result of this comparison at 75% maturity of the data set. And what they have seen is actually there is an overall survival benefit of about 4 months absolute survival benefit favoring the 500 milligram loading dose arm. So that is basically now that sets in stone that 500 milligram is the real dose that needs to be used if we are to consider this agent for treatment. Another question that comes up is what should be the ideal sequence of treatment with these agents, whether we can use fulvestrant in the first-line setting when we are starting a patient on hormonal therapy. And this question was attempted to be answered in this phase 3 study called the FIRST trial. It was a smallish phase 3 study, about 200 patients randomized to receive either fulvestrant or anastrozole in the first-line hormonal setting. These patients were chemotherapy naive. Fulvestrant dose was the standard dose. Luckily, it was 500 milligrams, day 1, 15, and 29. And unfortunately, this trial did not look at overall survival as one of its endpoints. Mainly, it looked at progression-free survival. And there was actually a progression-free survival favoring the fulvestrant arm. As I mentioned, this was a small study, so overall survival data were not collected. So does this really mean that fulvestrant can be used in the first-line setting? Well, we need a larger study, and we need to look at overall survival really to answer this question for sure. So for this reason, in July of 2012, a larger clinical study called the FALCON study has been started accruing patients. And this study is going to plan to enroll about 450 patients, postmenopausal, similar design, frontline setting for endocrine therapy. And this time it will be also double-blind placebo-controlled. So anastrozole will be given in combination with a placebo intramuscular injection. and fulvestrant will be given in combination with the placebo pill. So we'll have to see, obviously, we'll have to wait for a few years to see the results of this. So what are the current NCCN recommendations based on these recent results? So let's see the NCCN and ESMO recommendations. For premenopausal patients, both authorities are recommending the same, basically ovarian androgen suppression with endocrine therapy, mainly tamoxifen. And for postmenopausal patients, the NCCN is still recommending any of these agents to be used in whatever sequence, aromatase inhibitors, tamoxifen, or fulvestrant. However, ESMO, keeping in mind these recent results, is actually recommending nonsteroidal aromatase inhibitors, followed by exemestane, followed by exemestane or fulvestrant in whichever combination, but starting off with a nonsteroidal aromatase inhibitor. But in the near future, when we have the Bolero-2 overall survival results available, most likely the authorities will incorporate everolimus in combination with a steroidal aromatase inhibitor, which is exemestane, in the second-line setting after failure of nonsteroidal aromatase inhibitors, followed by tamoxifen or fulvestrant. And when we have the Falcon study results finally available, hopefully, or maybe we can see fulvestrant being incorporated into the first-line setting as a valid option for treatment for these patients. So what about chemotherapy updates in 2012? There was not much regarding chemotherapy, as was the case with adjuvant treatment. These are some single-agent chemotherapeutic agents listed by NCCN. As we can see, there are quite a few agents that are available for use. And most of the data that we saw in 2012 had to do with microtubule inhibitors and taxanes and capecitabine. But really, we are not likely to see a lot of progress in the chemotherapy area unless we start identifying biomarkers and start selecting patients for particular chemotherapeutic agents. These results are from this study, is actually called CLGB 40502. This is one of the studies that were presented in ASCO of 2012 last year. This study was presented by Dr. Sandra Swain, who was the president of ASCO, directly comparing 3 single-agent chemotherapy agents, including paclitaxel, nab-paclitaxel, and exobepilone. In the first-line setting, these patients had not received any prior systemic chemotherapy and had not received any adjuvant chemotherapy in the last 12 months before randomization. And this was a fairly large trial, about 800 patients randomized to receive either paclitaxel weekly, nab-paclitaxel weekly, or exobepilone weekly. Exobepilone is a novel microtubule inhibitor, and nab-paclitaxel is nanoalbumin-bound paclitaxel, which theoretically should have less neurotoxicity because of absence of cremophore, which is a solvent that's used to prepare paclitaxel. So let's see the results. So the progression-free survival results, actually, interestingly, were basically showing inferiority of exobepilone versus paclitaxel. In progression-free survival, we can see that the p-value is significant. And nab-paclitaxel and paclitaxel were pretty equivalent in terms of progression-free survival. But more importantly, when we look at tolerability, which is basically what we have to keep in mind when treating metastatic breast cancer patients because the treatment is palliative, we see that as the number of cycles basically went on, as we see on the x-axis, the rate of discontinuation of nab-paclitaxel and exobepilone, which are the red and green bars respectively, was much higher as compared to the discontinuation rate of paclitaxel, which basically tells us that paclitaxel is a much better tolerated agent. It is basically the agent of choice in the first-line setting. Another trial that was presented in San Antonio last month was a phase 3 eribulin versus capecitabine trial. Eribulin is a microtubule inhibitor which has been available for treatment in the US for about a few years, typically after failure of an anthracycline, a taxane, and a capecitabine or 5-FU-based agent. This trial was intended to bring eribulin into the third-line setting, and that's why they compared it with capecitabine. These patients all had prior treatment with anthracycline and a taxane before randomization. The dose of eribulin was 1.4 milligrams per meter squared. It was given day 1 and 8 every 3 weeks. Capecitabine dose was 1,250 milligrams per meter squared, which is probably higher than most patients would tolerate, at least long term. So what we saw as results was that the median overall survival had a trend towards eribulin, favoring eribulin, but it did not reach statistical significance. The p-value was 0.06. And the progression-free survival and overall survival were pretty equal between the two arms. So this puts eribulin as an option in the third-line setting, along with capecitabine. So it's good to know that this agent is available. I don't believe that's available in Saudi Arabia at this current time. Toxicity-wise, it was interesting that the toxicities of eribulin and capecitabine were not overlapping. So if we have a patient in the third-line setting who has more hand-foot syndrome, who's basically worried about hand-foot syndrome or diarrhea because of some reason, and would not mind neutropenia and alopecia, they might be better candidates for eribulin. So finally, HER2 inhibition. Most of the news that came out in metastatic breast cancer last year was regarding HER2. The most interesting news, at least, was in the HER2 area. And we have a couple of new interesting agents. The first one is this agent called pertuzumab. Pertuzumab is similar to trastuzumab in that it is a monoclonal antibody against the extracellular domain of HER2. It is different from trastuzumab in that the epitope of attachment of pertuzumab is a different epitope as compared to the attachment epitope of trastuzumab. So these agents don't compete with each other, they actually work in synergy with each other, and early clinical trials have confirmed this synergy. The mechanism of action of pertuzumab is basically blockage of heterodimerization of the HER2 receptor with the HER1, 3, and 4 receptors, and by doing that, there is an inhibition of downstream signaling from the cell surface to the nucleus to prevent cell growth and proliferation. In addition, it also activates antibody-dependent cell-mediated cytotoxicity. So this agent basically, after initial phase studies, was evaluated in a large phase 3 landmark study called Cleopatra. This study presented its results in late 2011, and it randomized 800 patients in a one-to-one fashion. These patients were metastatic breast cancer, obviously HER2 positive, who had not received any prior chemotherapy or biological therapy for metastatic breast cancer. And they were randomized to receive trastuzumab and docetaxel with or without pertuzumab. So it's the first study basically combining two anti-HER2 agents. Interestingly, as you can see, the pertuzumab dose that they used is a standard fixed dose, 840 milligrams loading, and then 420 milligrams Q3 weeks, so it doesn't have to be dosed differently for patients. Initially, what we saw was there was a progression-free survival benefit, strongly favoring pertuzumab. This progression-free survival benefit was 12.4 months in the placebo arm and 18.5 months in the pertuzumab arm. Later on in the San Antonio breast cancer meeting, what we saw was that there was an overall survival, median overall survival that had been reached in the control arm, but median overall survival has not been reached after 3 years of follow-up in the pertuzumab arm. But nonetheless, we could perform an interim analysis, and we can still compare these arms as an interim analysis. And when we do this, there is a strong overall survival benefit also favoring the experimental arm with a combination of pertuzumab, Herceptin, and docetaxel. With the p-value that's very significant, the hazard ratio is 0.66, which means a 34% reduction in the risk of death at 5 years. And this is not at the expense of a lot of increased toxicity. As we can see, pertuzumab, when added to trastuzumab and docetaxel, only increased febrile neutropenia grade 3 and 4 from 7 to about 14%. And actually, we are not really worried about increased cardiac toxicity. There may be actually a protective effect. As we can see, the LVEF did not drop significantly. Actually, the decrease in LVEF was actually less in the pertuzumab arm, 1.2% as compared to 2.8% in the placebo arm. So what does this mean?
Sayyid, I remind you of the time, huh?
Sorry?
We passed our time.
Yes, I think I'm just like few last slides, just going to finish. So the pertuzumab did not only show us median progression-free survival and overall survival benefit, but there's a trend towards median overall survival benefit, not at the expense of increased toxicity. So this is very interesting. And now an adjuvant trial is now being run, already started accrual, basically bringing pertuzumab in the first-line setting in combination with trastuzumab. So we'll see what the results are. It's a big trial, 3,800 patients are planned to be accrued. And I'm going to finish it with introduction of this another new anti-HER2 agent called trastuzumab DM1. This agent basically is just trastuzumab along with conjugation of chemotherapeutic agent called emtansine, which is attached to the FC portion of trastuzumab. And after attaching this agent to HER2, this whole complex is internalized. And then after this internalization, emtansine is released into the cytoplasm and leads to inhibition of microtubule polymerization. A large phase 3 study called the Emilia study, 900 patients. The results were presented last month in San Antonio, directly compared trastuzumab DM1 and capecitabine and lapatinib, which is a standard combination after failure of first-line Herceptin. Trastuzumab DM1 dose was 3.6 milligrams per kilogram. This comparison basically showed that there was a significant progression-free survival benefit favoring the trastuzumab DM1 arm as compared to the lapatinib and capecitabine arm. And not only this, there was an overall survival benefit also favoring trastuzumab DM1 as compared to lapatinib and capecitabine, 64.7% versus 52%. Toxicity-wise, actually very well tolerated. The only side effect we saw was, in addition to whatever we see in lapatinib and capecitabine, is low platelets in about 13% of patients. So this is another exciting agent. So now what we have is 4 different anti-HER2 agents available for treatment of HER2-positive breast cancer. And the questions that are still being worked on is how to use these agents in combination with each other or in sequence with each other. And we will have to wait for a couple more years to see what is the standard. So just to summarize, in advanced breast cancer, what we saw in 2012 was that everolimus significantly improved progression-free survival in combination with exemestane. This should be exemestane after non-steroidal aromatase inhibitor failure. Also, there is a promising new agent called PD991, which is now being evaluated in larger studies. The optimization of sequence of chemotherapy agents is still ongoing. And there are a couple of new exciting agents that are soon to be available for treatment of HER2-positive breast cancer, pertuzumab and trastuzumab emtansine or trastuzumab DM1. And with this, I would like to finish, and I would like to answer any questions in the end. Thank you.
Thank you. Shukran. Thank you, Dr. Said. Our next speaker is Dr. Jean-Pierre Girard. He's going to talk about a possible role of intraoperative irradiation. All the other 3 speakers, they were much younger than me. I was worried, you know, if there is somebody my age in this room. So it's nice to see Dr. Girard, who was a professor at the University of Lyon. And he has, from his CV in here, quite interest in developing X-ray brachytherapy for tumors. And it seems his main interest is in rectal tumors. But I think this technology will be developed and moved to cancer breast in their institute. So I'll be very interested to hear what Dr. Girard is going to be saying. 20 minutes, Dr. Girard, again.
Well, thank you, Mr. Chairman. I would like to thank this King Abdelaziz University for its very kind invitation to participate to this unique conference, and I will speak of the possible role of IORT, and mainly with 50 kV in early breast cancer. We are now moving from advanced cancer of the breast to early breast cancer. I've been working since more than 40 years with this kind of machine. I'm interested in proton, big machine, but also in small machine, providing with a small tube 50 kV X-rays. And this was the Philips machine, and now we have new machine that I name according to my mentor name. In breast cancer, one of the most important breakthrough was this randomized trial done by a surgeon, Professor Veronesi from Milano, who demonstrated in 1981, in July 2nd, that a conservative treatment with lumpectomy and irradiation was giving exactly the same survival rate that radical mastectomy, which for the woman was a complete change. And it was so important that on the same day of this publication, in the New York Times, July 2nd, it was on the front page. We are not anymore obliged to remove the breast. And that has changed the whole life of women in breast cancer. It is now clearly demonstrated that when you do meta-analysis, when you do irradiation or no irradiation, you increase by 18% the chance of avoiding a local recurrence. And it is said that you also gain in survival, which I'm not so sure, because this is mainly due to the Danish trial, but for sure, when you do a lumpectomy, if you add radiotherapy, you decrease the local recurrence rate. So radiotherapy in breast cancer, a major role in conservative treatment, better local control, improved survival probably. Of course, we have to give the optimal dose, and at the present time, local relapse is less than 5%, and the cosmetic of the results is good in most of the situation, and most of the women are satisfied with these results. What are the recent trends? Two trends. Hypofractionation, not anymore 5 or 6 weeks of irradiation, but 3 weeks, maybe less. And then accelerated partial breast irradiation. Don't irradiate the whole breast, but to improve the quality of the cosmetics, maybe irradiate just part of the breast, to reduce the constraint of treatment and to increase the socio-economic efficiency of the treatment, which at the time of the financial crisis in many countries is important. First, and briefly, hypofractionation. In Nice, where we have a lot of elderly patients, because it is a sunny part of France, we have treated, after tumorectomy, patient with 30 gray in 5 fraction of 6 gray over 5 weeks. At 6 years follow-up, grade 3 toxicity less than 5%, local recurrence 2.3%. It was published. But most importantly, this is a personal experience, there is randomized trial, which gives you the strong evidence. And this British doctor has made his whole life in this field, and when you look at randomized trial in Ontario, in UK, more than 5,000 patients, 40 gray in 15 fractions 3 weeks is equivalent to 50 gray standard treatment in 5 weeks. And now in the present time, 3 weeks treatment, 15 fraction is becoming standard in most of the European countries. And you can go still faster, and this is the UK FAST trial with 900 patients, and there you have 20.5 gray in 5 fraction. You remember that in Nice we give 60 gray in 5 fraction, 5 weeks, and no side effects. So maybe in the future, a 1-week treatment will become standard treatment. Let's go now to partial breast irradiation. There is at the present time a lot of ongoing trials, and we have no strong evidence. There is many different techniques, as there is many new drugs for chemotherapy, for targeted drug therapy. We have many different techniques of radiotherapy. We can do brachytherapy interstitial, we can do mammocyte, we can do 3D conformal, sometimes with protons, or we can do intraoperative radiotherapy, that a treatment during surgery with the surgeon in the OR. The question when you do partial breast irradiation is, where are the clonogenic cells who will give rise to a local recurrence after you remove the primary? This is the breast. If the tumor is here, of course you need whole breast irradiation. If it is just here, you have to irradiate this volume, 200 cc, and you can do that with external beam. If it is just here, more close in the index quadrant, maybe electrons or interstitial implant is enough. And if it is just close to the primary, in a shell of 1 centimeter thickness, maybe something like mammocyte or 50 kV is enough. Nobody knows exactly where is the CTV, and only a randomized trial will give you the clear answer. Where are the clonogenic cells? When you do a mastectomy specimen, in 50% you find invasive or in situ in remote quadrants, but 90% of the recurrence are in the index quadrant. The same when you do an autopsy for a patient dying on car accident, in 33% you find invasive or in situ in middle-aged patient in the breast, but only 8% of these cells will develop cancer. So maybe this is what they call now sometimes dormancy. So remote cancer foci do not in general give rise to local recurrence, which more probably develops from the cells. This is the hypothesis of the oncologists arguing for partial breast irradiation. What kind of technique? When you have a large volume, 200 cc external beam, smaller volume, brachytherapy or electrons, IORT, very small volume, mammocyte or 50 kV. Big volume, 200 cc external beam, smaller volume, IORT or interstitial, still smaller volume, 20 cc just around the tumor bed, 50 kV IORT. external beam radiotherapy. Paper, you can do 3D conformal, you can do IMRT, you can do tomotherapy, you can do protons. If you look at the dose in the remaining part of the breast, in the lung, in the heart, protons in all the cases is better, but of course, proton is not yet a standard treatment in rectal cancer. Electron beam, this is the Italian, you have the Mobitron in North America. You operate, you put a lead shield on the pectoralis major, you close the tissue of the breast, you put the applicator, you need a large scar of 8 centimeters, and then you irradiate. This is the Novak, and there is an Elliott trial done in Milano and in Italy, and these are the results, more than 1,800 patients, external beam, 6 weeks, IRT, 1 session during surgery and nothing else. Cosmetic result, slightly better with external beam, overall survival, as usually no difference. You look 97% of survival, local relapse, slightly more with IRT, but if you take the good risk patient, the same result with electron IRT. This means that you have to make a very strict selection to do electron IRT. You can do interstitial implant during surgery. This is picture taken in Nice, and this is a dose display, and you cover a large volume. And this is the Jericho trial in patient more than 70 years, lumpectomy, HDR, 34 gray in 2 fractions per day in 5 days. Toxicity, no local relapse so far, and it has been published. The mammocyte, this has been very popular in the United States. You inflate the balloon during surgery in the tumorectomy cavity, and then you implant here an iridium source to irradiate the shell here. Recently, in San Antonio, there have been some criticism, and when you look at the data from the US Medicare, you have whole breast irradiation, you have mammocyte, more abscess, more mastectomy, so you have to introduce it very carefully, and this is still a controversy. Let's go now to the 50 kV IRT. This is the intrabeam, which is performed in England, in Germany. The machine is done by the Carl Zeiss company. This is the source. You introduce and you irradiate. The machine, which is mounted here, you remove the tumor, you take the applicator, you put it in the tumor bed, and then you introduce the tip in the center of the tumor bed and in the applicator. Removal, applicator, you close, and you irradiate, and you can spare the skin. 20 gray in 30 minutes. It takes time, and the surgeons sometimes are a bit reluctant to take 30 minutes. No problem of radial protection. This is the patient, the breast, and you can do 500 IRT with some shielding without any problem. Randomized trial again, the target trial that you have heard, 28 centers throughout the world. They randomized lumpectomy and 50 gray, 5 weeks, 60 gray, IRT 20 gray in 30 minutes. More than 200,000 patients, 13% were positive with CRM positive margins. Results, external beam, IRT, toxicity, IRT, no toxicity at all, a bit more seroma, but not too much, 2%. No difference in infection. Local relapse at 4 years. It was in the Lancet published the same, good cosmetic results. But recently in San Antonio, they have made an update of the trial with now 300,500 patients, median follow-up 5 years, more than 1,000 follow-up more than 5 years. 15% of the patients had IRT and whole breast irradiation because they found on the participant some negative findings, so they add some external beam irradiation. Local relapse, now a bit more in the IRT, 2.5%. Overall survival, no difference. Maybe more intercurrent deaths when you do whole breast irradiation. This is a point which should be discussed. So that means there is still controversy in this field of 50 kV irradiation. What we know that there is, of course, some evidence of the benefit of this 50 kV radiation. You irradiate small volume. It is very accurate. It is vision guided. You have an immediate radiotherapy which may have some biological implementation and benefit. Don't forget that the RBE of 50 kV is a bit higher than the cobalt or the X-ray at 1.3 or 1.7. IRT alone, 20 gray, or with external beam is feasible. It seems to give quite good local control, accessible toxicity, and cosmetic. Weak problem, 30 minutes. This is a problem now. Second radiation-induced cancer. With long survival, you see some breast cancer in the remote and the other side of the breast. So you have to find, when you give 40 gray to the breast treated, what is the dose to the contralateral breast? With whole breast, 590 milligram, half a gray. With IMRT, 1 gray. With accelerated partial breast, 100, and with 50 kV, only 100. But of course, this is not relevant when you are treating patients of more than 70 years because the risk of second radiation-induced at this age is very low. But more importantly, aging of population. In 2013, 10% of the women are above 75 years with the breast cancer in France. We have 6,000 breast cancer patients above 75 years of age. And in this age group, a 6-week treatment sometimes is too heavy. And in some years, it will be the double. It will be 12,000. So aging of the population is really a very important socioeconomic problem. Can we omit radiotherapy after 75 gray? Well, the US trials say when you compare tumorectomy and tamoxifen and tumor and all breast, a bit more relapse with tamoxifen, but no change. And the NCCN guidelines say you may reasonably omit radiotherapy. On the opposite, when you look at randomized trial, in all the randomized trial, no radiotherapy, more local relapse than with radiotherapy, even in situ. And the German guidelines say post-op radiotherapy, whatever the age. So you see, according to the country, the guideline may be different. Alternative to intrabeam, electronic brachytherapy with the accent or interstitial implant, or X-ray with the papillon endocavitary irradiation. This is the accent trial, and this is the papillon machine. A new tube. This tube is able to irradiate the whole sphere. We have tested some specific applicator with some eyelets and some rims. We have different kind of applicator. We can use it according to the size of the tumor cavity. We have made a special niche breast applicator with a specific patent. This is it. You irradiate this shell around. This is the machine. This is the applicator. You introduce with the surgeon. You fix it, and then you introduce it. And the main advantage of this machine is that you give 20 gray not in 30 minutes, but at 3 minutes, because you have a special cooling of the machine here. We have been doing some dummy clinical tests during the past years with this new applicator. Now we will start in 2013, and we will have a very strict selection. Only patient more than 71 with T1, T2 less than 3, and we will give 20 minutes and 20 gray in 3 minutes with in vitro dosimetry. Obviously, X-ray brachytherapy with the intrabeam trial is getting to a renaissance. The target trial has given some evidence. IRT breast is strictly selected cases is necessary, and our opinion is that we should recommend this patient for elderly patient above 70 years where the risk is lower and where the constraint of the treatment is higher. So to reduce the 5 weeks or 6 weeks to this patient is a good indication. The dose rates for the surgeon is crucial, and the main advantage of the Papillon Plus machine is that you irradiate in 3 minutes and not in 30 minutes. Accurate, high dose, little constraint, and this is a good balance. And in conclusion, X-ray brachy IRT for breast cancer is still clinical research. The main point is you have to select your patient for this. The age is a very important factor, and you should restrict your indication, in my opinion, to patients above 70 years of age. You should ask the information and the consent of the patient, and of course you have the choice between radiotherapy or 5 years of hormonal treatment, accelerated partial brief 5 fraction or 5 weeks, 5 weeks of radiotherapy of IORT, 1 session and 1 session in 30 minutes or in 3 minutes. And of course, only good clinical trials will bring the evidence, but there is a place in the future for this X-ray 50 kV brachytherapy for IORT in breast cancer. Thank you for your attention.
Thank you. Dr. Gerard, could you join us on the podium here, please? So we can start our questions for the speakers. Please introduce yourself. Come to the microphone, introduce yourself. And we limit ourselves, please, to questions. I don't think we're going to need a lot of comments, you know, so let's make use of the speakers. Huh? By the time the people warm up, I just want to ask, Dr. Ahmed has to leave for some family reasons, so I'll ask the question about tamoxifen for 10 years to all the speakers. Huh? The way I understood it from Dr. Ahmed, if I have a premenopausal lady, she is receptors positive, he's going to give her tamoxifen now for 10 years instead of 5 years. This is what you do in your practice, or?
We haven't really adopted the same sequence yet, and I think it depends on the initial risk of this particular patient where you would like to consider 10 years versus 5 years. So if it is really a high-risk disease in premenopausal women, I think the idea is right. We should be able to do that.
10 years.
You know, I would agree with Dr. Yunus here that, you know, you have to really identify higher risk patients. And if they're basically, for example, a premenopausal patient who is finishing her 5 years, she's asked me a question of whether, you know, she should continue for more or not, you know, I think Atlas has provided a strong enough evidence favoring 10 years.
Any comments, Dr. Jiran?
Well, I follow the evidence, and if my medical oncologist said 10 years, I will give 10 years.
All right. Any questions from above, below? Yeah, go ahead. All right, while we get it to work, we use the intra-beam in here, in our hospital. We've been using it since 2010. We see more advanced disease than Europe, but we recruited 45 patients, which we're going to publish soon. 1/3 of the patient is being used as the boost, you know, because they turn to have positive notes, or, but 2/3 of the patient is the primary treatment. We really believe that giving the radiotherapy should be in theater. This is where you have the cavity open, the time is right, but only time will tell, you know. The target trial, the local recurrence, when they broke it into 2 arms, the arm where they had it immediately, and the other arm of the patient had the lumpectomy, and then they came for the intraoperative radiotherapy in another operation. They found that the local recurrence is 1% in the arm who had the immediate radiotherapy, which is not different. Yeah.
Assalamu alaikum. Question for the last speaker, Dr. Gerard. My name is Abdellah Al-Hawsawi. I'm one of the surgeons at King Abdulaziz University Hospital. So for the intraoperative radiotherapy, the way that the breast conserving surgery works is you do the lumpectomy, and you know, by the time you do you send the patient for radiotherapy, the biopsy results come back, and you find out whether or not you have positive margins. But in case of intraoperative radiotherapy, you're given the radiotherapy. So what if the margins come back positive? What do you do? Like, do you discuss it with the surgeon to go back and do more resection, or do you basically just are you comfortable with just radiotherapy?
So the question in 2 words: give the intraoperative radiotherapy and the margin came positive. What to do?
Well, this is of course a very important question. When you do IORT during surgery, you don't know all the pathological parameters of the tumor. Are the margin positive? Are the node positive? Do you have some extensive in situ tumor in the breast? And of course, according to this negative parameter, the risk of local relapse outside the small volume is higher. One solution that we are developing at the present time is to do this interstitial implant that I showed during surgery. You leave the applicators and the needles during 1 week. You wait for the pathological report, and 1 week later, the patient comes back and you do the irradiation. If there is no risk factor, you do only the local irradiation. If there is a risk factor outside this small volume, you give a lower dose of brachytherapy and you do external beam radiotherapy. Now, if you do the 50 kV IORT, if you do it at the time of surgery, when at the end you come with R1 resection or some negative parameters, there's been a long experience of 20 gray 50 kV IORT with the intrabeam and 50 gray external beam irradiation. So it is possible, and this is what happened in the target trial, to combine this IORT 20 gray at the surface of the applicator with external beam for the whole breast. And what we are planning is not to give 50 gray in 5 weeks, because we are dealing with elderly patients, sometimes living far from the hospital, but to give this fast trial standard treatment in UK of 5 fraction of 6 gray or 5.75 gray combined with the 20 gray. So this may solve the problem of negative finding at time of surgery.
Yeah. Yeah, go ahead.
The question is for any of the speakers, as long as Dr. Ahmed Sherry, he left, so maybe Javid can answer. You know, from the Swedish trial long time ago, when they were recommending or comparing tamoxifen for 5 years versus 10 years. Now, and that was declined because of the side effects, the long-term toxicities and the endometrial CAs, etc. Now we have the study of recommending using tamoxifen for 10 years, and from the side effects point of view, is not that significantly different. So what's your approach now? Will you recommend using tamoxifen for 10 years, or will you wait for some time, or will you go for tamoxifen followed by aromatase inhibitor, or like letrozole or whatever? So which one will you recommend?
Same question again raised about tamoxifen for 10 years.
So when the original presentation was done at the meeting, a number of people came up to the mic and asked a very similar question, that if it is for postmenopausal women, would you consider aromatase inhibitors instead of continuing tamoxifen? And I think this is absolutely true. If you believe in aromatase inhibitors for postmenopausal women, the best chance would be to put the best step forward and use aromatase inhibitors, not use tamoxifen for 10 years. And I think, so this basically relates to only a small proportion of women who have intermediate or high-risk disease, premenopausal strictly, and then you can certainly consider using tamoxifen for 10 years.
Just a follow-up to that question, actually. So did the ATLAS trial show benefit, particularly in premenopausal patients in their analysis, or I'm not aware of the details. Are you aware of any?
The presentation did not really segregate premenopausal versus postmenopausal, but the presenter answered the question exactly the same way, that he believes that the real impact is going to be the premenopausal women benefiting from it.
Can I ask a question? Dr. Yunus, thank you for that, interesting data regarding the use of, bisphosphonates in the adjuvant setting in breast cancer. In your opinion, and from what you know, is this effect in, the progression or recurrence-free survival benefit, is this coming from an anti-tumor effect of bisphosphonates, or is it, some kind of protective effect of the bone, which is not an anti-cancer effect? Do we have evidence regarding that?
Honestly speaking, I don't know the answer to this question, because none of the presenters nor the scientific data really relates to this. And I think perhaps the answer is a combination of the two, because these agents definitely change the local environment for the bone, and then they also have some anti-angiogenic effect on the bone marrow as well as the bone environment, so somehow or the other they change the things. I think the larger question is that, are you convinced that with all the data that we have seen, should we be using Zumeta or denosumab in an adjuvant setting or not? And I'll give you the answer from my own practice, that if I see patients that have very high-risk disease, they are postmenopausal, definitely, and they may have even a slight hint of osteopenia, osteoporosis, I'll certainly offer them as one optional therapy, clearly indicating that this is not standard of care, but it has a potential to produce the advantage.
Thank you.
In my practice, when we use aromatase inhibitors in the adjuvant setting, and if they have risk of osteopenia or osteoporosis, I typically incorporate bisphosphonates, so that might provide a beneficial effect.
Could we have more questions if there is questions? From upstairs, downstairs? I can ask a question to the speakers. Don't you really believe in intraoperative radiation? That's the best time to give essential treatment or a boost. And if you believe in that, why this intra-beam or any source of intraoperative radiation is not gaining a lot of acceptance, and there is a lot of controversy and a lot of discussion in this subject, If you did not give the primary treatment, you can still give external beam irradiation. We start with you.
Your question is, why this intraoperative radiotherapy, which is so simple, is not more widespread use?
That's true.
Because it is not a question of belief, it is a question of scientific proven evidence.
But the target trial is a good trial.
So far, even the Elliott trial and the target trial, which I think are good trials, are not giving strong evidence enough on the long terms to convince most of the population. And then, of course, as always, there is the resistance of people believing in standard treatment. Look, for example, I was in Lyon in 1970. During 10 years, I was doing lumpectomy and cobalt irradiation. And everybody was saying, you are a criminal to do that.
Yes.
It was not until Veronesi published his paper that science changed the opinion and people start to believe that at that time. I think that in 10 years, IORT in elderly patients certainly will gain a larger place. But we still have to accumulate scientific evidence.
Can I ask a question?
Yeah.
So, Karim, we face the same problem of finding out the order in which to use medicines in metastatic breast cancer setting, which is really what you were describing. So considering the HER2 new agents, can you, in your mind, place where to use Herceptin versus lapatinib versus pertuzumab versus TDM1?
Yes, from the evidence so far, the Cleopatra trial has moved, pertuzumab in the first-line setting in combination with hertuzumab, with the trastuzumab or Herceptin. So that trial, showed progression-free survival, overall survival favoring this combination. So in the first-line setting, very soon, I think, when the agents are becoming available, hopefully soon in Saudi Arabia, I think the practice is going to change to incorporating these two agents because there's not much increased toxicity with the addition of pertuzumab. So that would be the first-line setting. The second-line setting, as I showed you the data from the other clinical trial, the Emilia study, trastuzumab DM1 is becoming the standard in the second-line setting. So whenever it's available, I think the practice is going to start changing towards that. And lapatinib capecitabine is now being moved to the third-line setting based on those results.
For the surgeons, they take blunt movements sometimes. There is not a single prospective randomized trial completed comparing open to laparoscopic cholecystectomy. Not a single one. But laparoscopic cholecystectomy is the standard of care now, and nobody is doing an open cholecystectomy. Because sometimes in medicine, prospective randomized trials and evidence-based medicine is the care and the standard, what we should be teaching in university. But sometimes we have to use our common sense, And that's why laparoscopic cholecystectomy is the standard of care. Thank you for this very interesting session.